Hello, everybody. Welcome to our next webinar in our DTx series. Very excited that y'all are joining us today. So today's webinar is from 11:30 to 12:30. We have Dr. Eliane Boucher speaking on increasing equity in digital therapeutics. So this event is a free event brought to you by Louisiana Department of Health, Office of Behavioral Health, Northeast Delta Human Services Authority, and Foundation for Wellness. It is accredited for AMA PR Category 1 credits, LPCs, and social workers. Full participation of this presentation is required to receive credit, and we monitor throughout the session. And in 1 week, you'll receive an email from Foundation for Wellness on how to get your certificates. As a reminder, if you dialed in by phone, meaning using the audio, not Zoom on your phone, and please email info@Foundation for Wellness. And in that email, please include your first and last name and the phone number you dialed in with so we can mark you as attended for the event. Okay. So this is webinar number 4 in our 6-part series. Please be sure to visit foundationforwellness.com/DTx to register for webinar number 5 and number 6. Also on that website, if you missed any of our previous webinars, you can go back and watch the recordings for it. It won't be accredited, but it's there as a resource for you. So please feel free to watch it and share it with your colleagues. Okay, so on to a little bit about our speaker. She earned her PhD in social personality psychology from Queen's University in 2009, where her research focused on the intersection of social psychology and mental health. After spending the first 10+ years of her career in academia, she made the transition to digital health industry in late 2019. She currently serves as the Senior Director of Behavioral Health Science at Twill, recently acquired by DarioHealth, where she oversees the program of research and analyzes consumer data to derive insights for product optimization and serves as a scientific advisor. She lives in Rhode Island with her 2 sons and a miniature dachshund, Pika. She has disclosed for the financial relationships, full-time employee overseeing program research for Twill. That was recently acquired by DarioHealth, and she is a full-time employed under the DarioHealth umbrella. So thank you so much for being here, and I'm turning over the floor to Dr. Lane.
Thank you so much, Ashley. You did such a good job of introducing me that I think I'm going to be able to skip past one of my slides here. Thanks, everyone, for joining me. I'm really excited to talk to you all today about the issue of equity in digital therapeutics. And I think one of the reasons when I started talking about this with the Foundation for Wellness about what we could do together, this was a topic that they brought up as a topic of interest that immediately just hooked me, because this is an area I feel really passionate about. And I think you're going to see by the end of my presentation today that I think it's an area that we still need to do a heck of a lot of growth in. So these are exactly the kinds of conversations that I think we should be having with folks like you, but also internally in the digital therapeutic space. So I think I'm going to be able to skip past this slide very easily because Ashley did such a great job, but I will emphasize that Twill, when I first started these conversations, I worked for Twill. Twill was acquired by DarioHealth, which is a publicly traded company, in February. I've since kind of merged over into Dario. So I used to have stock options in Twill. Those have now been converted to both vested and unvested stock options in DarioHealth. So just to be really clear there. My objectives today really are, aside from just hoping to get you really excited about the idea of digital therapeutics and the potential for digital therapeutics in increasing equity, I really want you to leave with kind of understanding and recognizing the advantage of digital therapeutics for increasing equity in care, but also the unique barriers that we really have to consider when we think about access and equity in digital therapeutics. So I'll get to this in a little bit, but we often talk about in my field about how we break down a lot of barriers in digital therapeutics. We talk less often about the new barriers that we might be introducing to care and to equity. So I'm going to spend a little bit of time talking about that so that you understand and you can start to think about them yourself. And then I really want to leave you with some information that arms you to be able to recognize the digital therapeutics that might be more appropriate for diverse or disadvantaged populations, and even leave you with a couple of resources that you can use if you're trying to do some research yourself. So I want to start out by really just, I think I'm probably preaching to the choir when I talk about the fact that access to mental health care is an issue in the United States, probably globally, but at least I'm going to try to focus in like the immediate environment that I'm living in, that I imagine most of you, if not all of you, are calling in from. And we do have a unique structure here in the US, and we understand that particularly after the pandemic, mental health in the United States has been worsening. We heard it early on in the pandemic that we were looking at the next pandemic was going to be the mental health pandemic. We hear about it less now, but really most of the data is suggesting that rates of depression and anxiety increased early on in the pandemic and really have yet to kind of resolve. So one kind of nice resource to be able to get a pulse check on mental health in the country is the CDC Household Pulse Survey. And in 2019, before COVID hit, about 10.8% of US adults screened positive for depression or anxiety using the PH22 or the GAD2. So it was one or the other. When you look at October 2023, this rate was nearly 3 times that at 34.2%. So this is not when we were kind of in the midst of the acute phase of COVID-19. This is really after, when we still saw these rates be really high. Now, I will mention that there has been a really interesting drop. If you are a data nerd, this is really interesting to go and look. That their last data point in 2023 was October, and it was at 34.2. There was this really marked drop in depression and anxiety rates on the CDC Household Pulse Survey until March, April 2024. So now it's at about 21.1%, which is still higher than what we saw, almost double what we saw in 2019. But may suggest that we're starting to see some improvements here. Maybe it's just kind of an aberration, something to keep an eye on. You couple that with the fact that practitioners who are working in the mental health space are responding to national surveys by saying that their patient referrals have increased. 62% of practitioners on APA's 2021 practitioners survey said that their patient referrals have increased since the start of the pandemic. 68% of them reported increased wait times. And in 2023, the most recent one, 38% reported more patients on their wait list than 12 months prior, so 2022. So which suggests that this isn't a pattern that is improving. This is a pattern that might be getting worse, at least for some folks. And really, if you think about it, you are all human and you can only see so many patients. So it makes sense that as patient referrals increase, we're seeing that the majority of practitioners who are responding to these surveys are saying they have no more capacity for new patients. And then that leads to increased wait times. So kind of what this all leads to is that a lot of people who need mental health care services have an unmet need. More than a quarter of people with symptoms of depression or anxiety are saying that they have an unmet need for counseling or therapy services. They cannot access the services that they need. And if we think about the fact that this is especially likely among people from marginalized backgrounds, so rates of anxiety and depression are significantly higher in some marginalized communities within the US, in particular transgender adults, where it's nearly 50%, LGBTQ, specifically looking at gay and lesbian adults, 32%, bisexual, 46.4%, adults with disabilities, 48.2%. Differences in terms of anxiety and depression by rate and ethnicity actually seem to be relatively small. There's some evidence that some racial and ethnic groups actually tend to be lower than Caucasian Americans, but the rates of increase in anxiety and depression tend to be faster, steeper in these groups than among Caucasians. And also the impact of these symptoms seems to be greater in these groups, typically because there is a greater unmet need. So if you look at the figure on the right on this slide, you'll see that this is over time the unmet need by race and ethnicity, so specifically white, Black, Hispanic, and Asian. And what you see is that in 2019, the unmet need wasn't particularly it wasn't necessarily higher in other groups, but you see a higher unmet need as you are going along until 2021. So we're seeing that although race and ethnicity don't necessarily predict worse mental health, it does predict less utilization and worse outcomes associated with those symptoms. So when we often talk about mental health care and the barriers to mental health care, we often talk about things like transportation and cost and other things that we can potentially change. But really what I think our biggest problem is that's much harder to overcome is an access problem. It's not just these barriers that we're talking about, it's a supply and demand issue. If we improve the barrier for transportation or for cost, but we don't increase the number of providers, all we're doing is making the problem worse. We're increasing those wait times, we're increasing wait lists. We need to really truly solve the access problem. We need more mechanisms to provide the care. And there's some research that suggests that without making changes to what we're doing now, we're projected to be short over 17,000 psychiatrists by 2050. And that's just psychiatrists. That's not including all the other types of practitioners and mental health care providers who are also in short supply. So this is not limited to psychiatrists. This is just a nice statistic to put up here. So when we think about digital therapeutics, I think one of the reasons why it is so appealing to us, and it is part of the reason why I joined the field, is that it does seem like a solution to this access problem. If it's really a supply and demand issue, particularly when we think about digital therapeutics that don't rely on a human factor, a human connection, then we can scale these types of programs without having to worry about the supply and demand. So I want to level set a little bit because I think, and I know that there's been some other presentations in this series, but I'm going to assume that maybe you haven't been able to attend all of those. And there's a lot of misunderstanding about what a digital therapeutic is and is not in the field. So digital therapeutics, by and large, were developed to help fill the supply gap, right? So they offer scalable and cost-effective care options. When we think about digital therapeutics, this is a term that a lot of people don't quite understand. And according to the Digital Therapeutics Alliance, they recently defined this as digital therapeutics deliver medical interventions directly to patients using evidence-based, clinically evaluated software to treat, manage, and prevent a broad spectrum of diseases and disorders. I'm going to focus on a special type of digital therapeutics today, largely because it's a field that I work in, but also because the research varies depending on what types of digital therapeutics you're looking at. So I want to kind of hone in on digital mental health interventions. So really focusing on mental health as the outcomes that these digital therapeutics are designed to target. So these are a specific type of DTx that are really meant to help prevent, manage, or treat mental health symptoms and disorders. To go a step further, I think a lot of the confusion about what digital therapeutics are comes from not really understanding the different types of digital therapeutics programs and the regulatory and marketplace implications of those. So when we think about digital therapeutics, we can think about them in three buckets. The first bucket, which we can think of as the lowest risk version of these digital therapeutics or digital mental health interventions. These are considered wellness products. They're considered low risk. They're not regulated by the FDA. In many ways, you can think about these as like over-the-counter medications, not regulated. They are, if you look at the FDA guidance, they really spell out wellness products as being intended to maintain or encourage a general state of health or healthy activity. They promote a healthy lifestyle to reduce the risk of or impact of certain chronic diseases or conditions, where it's well understood and accepted that healthy lifestyle choices may play an important role in health outcomes. So in this category, there is really a broad spectrum of the types of interventions that you might encounter. They can range from anything that might not even be evidence-based or have research to support it, to wellness products that are really focused on well-being and promoting a healthy lifestyle, but are really quite evidence-based and rigorous. So the evidence, kind of the bar for evidence, I think sometimes people attribute to wellness products aren't evidence-based. That's not necessarily true. You have to dig a little bit deeper. But what is often the case is that wellness products tend to be still direct to consumer. So Calm and Headspace are good examples of this, where you can go and get them in the App Store, or they can be provided through employee benefits, or sometimes through health plans. But when we think about the cost here, by and large, for most people to access these products, unless they're lucky enough to have these as a free benefit, they have to pay the monthly costs themselves. If we move over into the middle bucket, this is what we call non-prescription digital therapeutics. So now we're really moving into products that have been designed and intended to help patients self-manage a condition. So we're no longer talking about promoting a healthy lifestyle and general wellness, even among people with certain chronic diseases and conditions. Now we're really talking about making changes to the symptoms or the consequences associated with specific conditions. So for instance, when we think about mental health, this might look like helping people with elevated symptoms of depression and anxiety, but not diagnosed, manage depression and anxiety. It might even look like helping to manage mental health outcomes in a pregnant population, because the population is now dealing with a condition. This is still a low risk product, and it is technically regulated as software as a medical device under FDA, but it does not require FDA clearance. It's under this enforcement discretion guidance that is pretty ambiguous. These kinds of products are rarely direct to consumer. They are more likely to be offered through employers, through pharmaceutical companies, or through health plans. So typically when a patient gets access to these, the costs directly to them might be different than in a wellness product. And then finally, on the far right, what we see are prescription digital therapeutics. This is really truly software as a medical device that requires FDA clearance. These are products where we are making claims about treating a disease. So now we are treating major depressive disorder, or generalized anxiety disorder, or even substance abuse disorder. And what's important to know is that even when you get FDA clearance with these products, they are still typically considered adjunctive to more traditional forms of treatment. So these are not meant to be standalone forms of treatment, but really something that is offered alongside psychotherapy or pharmacotherapy or something else. There are some really great examples of prescription digital therapeutics out there. EndeavorRx is one that was cleared for ADHD in youth. And this one is one that's been in the news because it was recently purchased by a different company. Rejoin is a new one for major depressive disorder. That's a combination of Otsuka and Click Therapeutics. And then Reset and Reset-O were two for substance abuse and opioid use, specifically. That used to be a company called Pear that went bankrupt and is now purchased by a different company. So you really see the different levels, but also the costs that are involved with the other levels. And what's interesting is the prescription digital therapeutics, when we think about it from an access standpoint, these are ones that when we think about access and equity, the idea was that they would be covered and reimbursable. So in theory, that would level the playing field a bit, at least for people who have health insurance. The problem to date is that reimbursement has not really materialized. So more often than not, even though these are FDA cleared and prescription products, they are still being paid for out of pocket by the patients themselves. And you're going to see in a second why that has some implications in terms of equity. So if we want to know, that there's a lot of promise to digital therapeutics in terms of access. We know that most people have phones now. We know that it's something that people can do from a rural environment. They don't need to worry about getting on a bus and getting to an appointment. So it solves a lot of the barriers that might lead to inequity in mental health care. But part of the problem is that we don't actually know if digital interventions are equitable right now, because we're not really asking the questions to figure out if they're equitable. So a really great example of this is a recent systematic review that was conducted that looked at all digital therapeutics research to understand what key demographic variables related to equity are even being reported in studies. So this doesn't mean being included in analyses. In fact, very few of these studies, if any, use these variables as moderators in their studies. but even just the basic level of reporting them as a way of describing the samples that they had. What they found was that race and ethnicity was one of the more commonly reported demographic variables beyond gender or sex, and those two were conflated very often, and age and education. What you see is that beyond those, race or ethnicity was the next one, reported at about 48% of the studies, more commonly in the US than outside of the US, which makes a lot of sense because it tends to be a construct that is less important outside of the US. When we look at other types of demographic variables related to equity, however, disability status was only reported in 2%, sexual orientation was only reported in 2%, and most of the studies were conflating gender and sex. So even when they referred to gender, they typically offered only two response options, male and female, which really doesn't allow us to understand other types of gender identities and the prevalence within studies or the products themselves. What we do know is that among the studies that do report on these characteristics, the samples are not very diverse. So Asian, Black, and Hispanic populations tend to be underrepresented in DTx research, which is just research. But again, if we want to know if these products are equitable, we need to understand, we need to have diverse samples, and we need to ask the questions. And currently, that's not really happening. The other thing that we have to understand is while it's really nice in theory to think about digital therapeutics as this utopian idea that's going to level the playing field, everyone has a smartphone, it's going to mean that everyone can access mental health care whenever, however they want it. The reality is that within the US, we still have a digital divide, and that digital divide maps on to the same SDOH variables that impact mental health care broadly. So these digital interventions break down some barriers, but they introduce new ones that we don't necessarily see in other more traditional forms of mental health care. So for instance, yes, most Americans own a smartphone, but it's not 100%. And when we look at the folks who don't own a smartphone, it's more likely to be low income, older adults, those with less formal education, all less likely to own smartphones. And most of these apps really depend on smartphones. And in particular, I will say that there are some of these apps that have not really been designed to be web friendly. Some of them are both mobile and web friendly, and others aren't. They really depend on the mobile app, which places folks who don't have a smartphone at a disadvantage. The other consideration is that there's evidence that in some low-income households, they actually share smartphones, right? Not every person in the household has a smartphone. And then that introduces new access and privacy concerns. If you're sharing a phone with someone that you're using to access your mental health app, is that private? Or do you have privacy when you're doing it? But also, can those other people access your data? So these are new concerns that we don't necessarily have in more traditional forms of healthcare that I think we don't always talk about in the digital health space. A related factor is access to broadband internet. So again, if you have a smartphone and you're low income, you may not have an unlimited data plan, or maybe you live in a rural area and you don't have great access to cell coverage where you are. So broadband internet becomes really important, but low income, racial and ethnic minorities, lower education, rural areas, all less likely to have access to high-speed internet. So again, this has implications for their ability to actually leverage the tools that we're making available to them. And then a third factor that we don't tend to talk about very much, but I think is really important, particularly as we start to think about digital health and interventions for older adults, for instance, is the concept of digital literacy. I think, again, because we have become so used to people having smartphones and understanding technology, there's often an assumption that everyone knows how to download an app, how to open an app, how to use it. And the reality is there are still a lot of people who are not comfortable with technology and are not very digitally literate. So when we look at age is negatively related to digital literacy in particular. If you go 75 and older, really a generation that did not grow up with technology, they are 4 times more likely to have low levels of digital literacy. Same thing with lower levels of education, people who live alone, having a lack of social support, all of these are related to lower levels of digital health literacy, which means that even if they have the ability to access these apps, they may not know where to go and find them. They may not know how to download them. They may not know how to use them. We really have to start thinking about, if we want to think about equity, how to level that playing field, how to provide some education. And there are some folks who have presented the idea of having a digital navigator, which is a human. So now we're limiting scalability, but this is really someone that, for people who have more difficulty when it comes to digital literacy, someone who can help them navigate all of these things that some of us may think as really simple, like downloading and opening an app, signing up for a program, using the program. This is someone who can help navigate those folks through those initial steps and help them become more comfortable. And that's something that we're not seeing really implemented in the real world digital health space, but that I think is particularly important. And then I think there's a big kind of elephant in the room that I tried to allude to before, that digital health and digital mental health interventions, while the potential was there for this to reduce the costs, particularly with a reimbursement model, the reality is that today it fails to address the cost barrier. So national surveys suggest that about 80% of US adults view cost as a primary barrier to accessing mental health care broadly, not just digital mental health care. For people, when we think about the unmet need, the people who say they need mental health care or who have symptoms, but they are not accessing those services, 20% of them are saying it's because they couldn't afford the cost. When we think about digital therapeutics, this problem may actually be worse than it is in traditional mental health care, because reimbursement is not typically possible. So these programs can cost anywhere from $300 to $1,500 per year. And because they are rarely covered by insurance, even when they are prescription products, these are costs that come out of the patient's pocket. And in reality, this is really what was one of the big downfalls for Pear Therapeutics and their Reset and Reset O programs. The program was over $1,000 for people to purchase it, and people just weren't buying it, because we know, even from pharmaceuticals, if people have to pay too much out of pocket, they will do without. So right now, we do not have a great solution to this problem, to this cost issue, that is really going to interfere with people in probably the most vulnerable communities being able to access these products, even if we can solve all the other problems in terms of equity. So for the rest of today, I want to spend some time talking about what we do know in some key areas of equity. And this is not going to be exhaustive. I'm going to talk about all buckets of digital therapeutics. So some would argue that wellness products are not actually digital therapeutics. For ease, I'm going to lump these all in together, because the research typically does not distinguish that well between them. And really what we want to know is, across the board, do these mental health and digital mental health interventions work in these types of populations? And what do we know now? So what we know from the research in terms of race and ethnic groups is that there might actually be greater interest in digital tools among racial and ethnic minorities. So remember, I talked about the fact that utilization of mental health care among some racial and ethnic minorities might be lower. And oftentimes when people are asked, it has a lot to do with some of the barriers I already talked about, but other unique barriers, like a lack of culturally sensitive providers, a lack of trust in the healthcare system. And in some cases, we can overcome some of these concerns with digital therapeutics. So some of the research has shown that even though access to broadband internet is actually lower in Hispanic and Latinx communities, they're actually 20% more likely to use health apps, not just mental health apps, but health apps broadly. So they have more of an access issue, but they are actually more likely to use these apps. Similarly, while there's research saying that overall interest in digital mental health interventions doesn't differ by race or ethnicity, they're actually more willing to pay for these digital health interventions than non-Hispanic white adults. So there was a really interesting study that asked people their likelihood to use it. That did not differ. Asked them kind of their likelihood to pay for it, that didn't differ. But when they asked about how much they would be willing to pay and what percentage of their paycheck they would be willing to pay, the racial and ethnic minorities, so specifically Black, Hispanic, Latinx, were more likely to say they would pay a higher value and a higher percentage of their paycheck relative to non-Hispanic white adults. There's also evidence that Asian students are more likely to care online only relative to white students in college. So this means that when they are thinking about how they would receive care, they're saying they would only do it online, whereas white students are equally likely to seek care online and face-to-face. But when we look at actual utilization rates, so all of these kinds of things, and remember the first one's for health apps broadly, there's data that suggests that they're interested. But when we look at actual utilization rates, the adoption rates and the utilization rates of digital mental health interventions are lower among racial and ethnic minorities compared to non-Hispanic white adults. There's very limited research on whether these programs are actually efficacious or effective in these populations. Incredibly limited research. To my knowledge, there's really 2 studies, one of which I did, looking at whether we see differences in the engagement with and the impact of these kinds of interventions. So in the one that I ran, we did an analysis, a retrospective analysis of real world users of a self-guided wellness program. So that far left bucket, a wellness program. And we did find that our signups were predominantly white, about 64%. And we did, kind of corresponding to the research I talked about earlier, find that Hispanic and Latinx and Black users were slightly underrepresented compared to the US Census data, and Asian users were slightly overrepresented, which may be a function of part of these users are actually coming from a business to business model where they are receiving access to the product via their employer. And some of these employers tend to have a higher proportion of Asian employees. So I think that drives some of these differences as well. But interestingly, although we saw these differences in terms of adoption, when we looked at the people who actually adopted and started using the program, we found no real differences in optimal engagement, the kind of engagement that we associate with improved outcomes on mental health outcomes. No real difference between white, Black, and Hispanic and Latinx users, though we found lower rates of optimal engagement among Middle Eastern users. We also found that across the board, the users who engaged optimally had better improvements in their well-being and in their anxiety symptoms, but we found no difference in those improvement trajectories by race or ethnicity when they were engaging optimally. So that gives us some sense that these programs can actually be efficacious if we can get folks to use them. Similarly, DarioHealth did a study with their blended care therapy. So this is a very different type of program where now there is a digital platform, but they're actually being connected with a real counselor. So this is, it still can fall under the digital health umbrella, but really now you have a human involved and it becomes more like teletherapy or an employee assistance program than self-guided programs. And again, they found that their users were more likely to be white, though less than 50%, and then followed by Asian or Pacific Islanders. Again, LYRA is offered through employee programs, so this could be a function of the types of demographics of the employers that they work with. And they also found that Hispanic, Latinx, and Black users were underrepresented. What they found was that Asian and Pacific Islander users completed fewer sessions or were less likely to recommend their therapist. But they didn't really find any difference in terms of the overall outcomes associated with their program, with engagement with their program, in terms of race or ethnicity. They did find some evidence that initial improvements were steeper in anxiety and depression. So there was a steeper drop in anxiety and depression symptoms among some racial and ethnic minorities, but that attenuated over time. So really what we're seeing so far is that these programs seem to be effective and probably not really any different when we look at racial or ethnic minorities. But the real problem is that these interventions are not typically designed with racial and ethnic minorities in mind. So culturally adapted digital mental health interventions have been shown to be acceptable, feasible, and efficacious, although some argue that they aren't necessarily superior to non-culturally adapted DMHI, so maybe it's not worth the effort. I would say there might be other benefits like being more likely to engage or increase adoption rates. But most of our digital health interventions are really not culturally adapted. And this is where user-centered design becomes really important, where we actually bring in people from the target communities or from diverse communities to be part of the design process to help us understand what we need to change or adapt to our programs to make it better suited to a particular population. But this is really only happening in maybe half of the digital health interventions. And I will say that that's actually probably really generous, because this was from a study that looked, this was a systematic review that looked at studies in the digital health space. And those include programs that are being designed by academics who might be more likely to be developing a digital health intervention from the ground up and involve populations, whereas in the real world, I would argue that this is probably happening even less than 50%. The other thing is that most digital mental health interventions are only available in English. So there's some research that suggests that only 14.5% of available mental health apps are offered in Spanish. And if we think about the fact that Spanish is spoken quite frequently in the US, either as their language, their first language, the language they're comfortable in, or their language of preference, this means that we are really not meeting a need for our Spanish-speaking population. I will leave with a silver lining in this area, that there does seem to be an increased focus on developing interventions that are culturally adapted to racial minorities. So there's some research that suggests that interventions that have been designed specifically with Black communities in mind can help with state anxiety and with depression and stress. So I think we're going to start to see an increase in these types of programs. I won't go into all of these because there's a lot, but I also want to mention that there's been some research that suggests that in addition to the barriers that I mentioned earlier to the adoption of digital mental health interventions that are unique to digital contexts, there also appears to be unique barriers to the adoption of these interventions among people of color. So in a recent study of students of color, and this was really not even surveying the students of color, it was surveying experts in the area to understand what are the potential barriers that might prevent students of color from engaging with a DMHI. And there were 63 barriers overall, but some are really focused on unique considerations for students of color. Things like mistrust of mental health services, systems, and providers, which we talked about, lack of culturally responsive services and providers. But then we also see some of the things that I think I just talked about as manifesting as barriers. So things like they don't see DMHI or apps as designed for BIPOC students. There's a lack of diverse representation and DMHI service content. So even things like the pictures that they see when they download the app, they don't see themselves in these apps. They don't necessarily think the apps are for them. That the use of modalities and theories are grounded in whiteness, lack of culturally relevant content. So these are all things that suggest that there is an understanding that the digital health interventions that we are designing and how we are marketing them is not necessarily thinking about these diverse groups. Moving on to the LGBTQ plus community, there is far less research here. Like I mentioned, even when we think about it being used as a descriptor for studies, it's only reported in about 2% of studies. And there's very few studies that are actually looking at this as a specific variable of interest. But there is some suggestion that in the LGBTQ community, there may be particular interest in seeking out digital means for support. We don't really understand why, but there's some other evidence that they might be more likely to look to the internet, to use text messaging or other ways of seeking out digital support. And there is some preliminary findings that digital interventions can be effective in this population in helping with things like suicide prevention, different types of psychological distress like depression, anxiety, and stress, or even substance misuse. But again, when we think about this population, user-centered design is really important here, even in terms of being sensitive to the language that we use in the programs that we have, the types of content that they would like to see, the imagery that's used. Involving LGBTQ individuals in the design is probably really important in terms of making these programs feel relevant. And even in studies of DMHIs that have been developed for this community, only half of those included community members in the design of the intervention. So if only half of the digital interventions being designed for this population specifically are involving these community members, then you can imagine that in the broad landscape of digital mental health interventions, it's probably very unlikely that LGBTQ individuals are being involved in the design process intentionally, either as part of the design process or even as part of the testing process. And then finally, I wanted to just leave on a note about people with disabilities, because I mentioned earlier that this is a population where we see that the rates of anxiety and depression are much higher than in the general population. But this is an area that has largely been ignored by the digital health industry. So we know from some other research on apps broadly that 1 in 4 people with disabilities report difficulties with accessing or managing apps. And for about half of those, that actually leads them to uninstall the app. It's too difficult, so they actually just quit using it altogether. This is a population where it's not just surface level content. It's not just the programs and the type of material that's involved. This is a population that is diverse in and of itself, that the disabilities can range from cognitive, physical, other types of disabilities, and there's diversity even within those buckets. And it means that co-design is probably particularly important in this population, along with including caregivers and subject matter experts in this work as well, not to overlook the patients themselves, the people with disabilities themselves, but also as extra voices to help us understand how people with disabilities may engage with our products, how that might be different from the ways that people without disabilities engage with our products, and the different ways that we need to adjust our products to meet them where they are. So there is very limited research here. There's some qualitative research that suggests that adults with intellectual disabilities can engage with DMHIs, and that this might be promising. But there's virtually no research on the utility of DMHIs with people with disabilities, particularly physical disabilities. And when we think about how many of the available apps are actually accessible, that is particularly low, especially when we think about the fact that there's some evidence that the rating methodologies for these DMHIs only focus on visibility or readability as an accessibility feature. They are not thinking about other things like, does the game need to be slowed down? They're thinking largely about things like, can you zoom in and make the font larger? And that's really a narrow view of thinking about disabilities. So this is really an area where we have a long way to go. So before I open it up for questions, and I did want to leave you with some time for questions, and I've seen some raised hands and I see 18 things in the chat. I just want to leave you with what my take-home messages are, and with a quote from Stephen Schuler, who is really an eminent researcher in the field of digital therapeutics and digital mental health interventions, where he says, as it stands, digital mental health interventions still hold a lot of potential to help diverse groups, but now that potential needs to be translated into reality and action. So for me, that translation needs to happen in 3 different ways. The first thing is cultural adaptation. We really need to start thinking beyond a one-size-fits-all approach, particularly because I think the evidence that we have so far, even though we are not asking the hard questions, tells us that the programs that we are designing, the one-size-fits-all approach, is probably fitting the majority white, affluent, highly educated, no disabilities group, and not really keeping in mind the other groups on the fringes. So we really need to think about designing digital interventions for underserved and marginalized communities, and in particular, involve them as co-designers, or at the very least, really do intentional, user-focused, patient-focused research that involves diverse populations. We need to consider translations and culturally adapted versions of existing digital mental health interventions. I think I mentioned earlier, the silver lining was that we're seeing a lot of interventions that are being designed for racial and ethnic minorities, which is fantastic. But part of the problem is that if we just create more interventions, we are just crowding the market more, which makes it hard for people to know what to find, what to start, what's for them. And it would be much better for us to have fewer platforms, fewer apps, but more within those apps that allows people from different backgrounds to be able to use them successfully. I think we also have an opportunity to leverage AI and machine learning to personalize interventions, though I think it is really careful here when we are thinking about equity, that there's a lot of evidence that AI algorithms can be biased because a lot of these algorithms are based on data that is coming primarily from white, educated, affluent individuals. And so they don't necessarily work for diverse populations. And there's been some suggestion of even using language agnostic interventions. So can you get away from the language issue altogether so you don't have to worry about translations by using images and other types of things that don't rely on language specifically? Second is the cost issue. If we really want to deal with the equity issue, digital interventions must be affordable, and I would say really reimbursable so that the cost is almost minimal to nothing for the user. That is really the only way that we are going to make these digital health interventions accessible to people from low income backgrounds and other people who may have a hard time paying these really high costs in some cases. So we need policy changes that are going to allow for reimbursement of digital therapeutics. This is something that the Digital Therapeutics Alliance is working on. This is especially true for mental health. I think the pathway to reimbursement is better for digital health programs that are focused on things like diabetes or musculoskeletal conditions. But for things like mental health care, it is much more difficult. And I think that's really where we need to focus in order to reduce that barrier. We are seeing some interest in these interventions from government programs like Medicaid and Medicare, where health plans who offer these programs are partnering with digital health companies as a way of making their programs more effective and more appealing. So we may see that that's one way that we can start to offer these programs at no cost to people from low-income backgrounds. And then finally, I say this a lot in my professional life, that we need to be asking the hard questions. And when you work in industry, it's easy for academics to ask themselves the hard questions because they don't really lose anything. But in industry, there are risks involved to asking the hard questions. You might find out that your program does not actually work for a population. And then what do you do with that? And do you want to market that? But I think so long as we are afraid to ask these hard questions, we are not really going to materialize the promise of digital health interventions as being equitable and as solving the inequity in mental health care. So in research, both from academia and from industry, our current evidence is primarily on weird samples, so Western, educated, industrialized, rich, and democratic samples. This does not necessarily generalize to other countries, does not necessarily generalize to other marginalized groups within the United States. So we really need to, as a field, start asking these hard questions to be able to start to fill in the gaps and identify where we need to make progress if we really want to deliver on this promise. So with that, I'm going to leave you on this page and turn it over. So we have 9 minutes for questions. These are some helpful resources that you can either take a snapshot or you can get access to the slides, including one that is actually a database that allows you to search for different types of mental health apps, including by cost, features, and if a Spanish language version is available. So with that, I'll be quiet and I will see if I can answer any questions. Thank you so much.
Thank you so much. Okay, the floor is open for questions. Please put your questions in the Q&A and we can answer that. So someone says, where does betterhealth.com fit in? How are the therapists regulated?
So that's a really interesting area that I will admit, because I have not worked in that industry, I am less familiar with. But I think a lot of these, what I tend to consider as being more teletherapy, so the Talkspaces, the BetterHelp, they are really not regulated in the same way, which I find personally very interesting. Like I have to deliver evidence that shows that our programs work. But in a lot of these other types of apps that are really meant to connect you to a therapist or to a counselor, as long as the therapist or counselor is licensed, my understanding is that is what is required. There's no additional regulation of those programs beyond that. And I think that's partly why we're seeing some controversy. come out with some of these companies as well.
I'm kind of going through the chat to see if anyone plugged in questions there. Any further questions from our audience? Or maybe let's pose a question for people in the chat. Have y'all used? What type of apps and web things have y'all used?
That's a great
Or
question.
have you used personally, or you have clients that use them, or you've recommended a particular one if everyone has a favorite? We got a quiet bunch today. We got a quiet bunch. Okay, so
Theranos and Zoom.
Zoom. Okay. Are you familiar with Theranos?
I am not. I would
Okay.
love to hear more about that. I'm going to take a screenshot of the list and go and add all of these.
Yeah, there's so many that just I feel like it's just such a I don't want to say an industry in its infancy, but I feel like the sky's the limit with this, where I know it's a huge industry, but I feel like it is just growing and growing.
It really is. And I think that's why I caution us to just develop more apps, because I think we're already overwhelmed by the number of apps that we have available. And I know, at least in the digital health space, what they are saying is over in the next year or two, we're going to see a lot of mergers and acquisitions. So I just went through it.
Mhm.
Headspace merged with Ginger, when Ginger is more of a teletherapy kind of service. We're seeing other companies that have big health acquired Spark X, and then there's some others. So I think we're starting to see where people feel like there's too much to keep track of, and
Mhm.
we're going to see them kind of consolidate a little bit, which is probably going to be good, because it's going to be easier for us to know what companies are doing good work and what do they offer, which for practitioners is going to be important, because right now it's really hard to know what to use, what to recommend, for instance.
And it's just like any other pharmaceutical or medical device, where the acquisitions are just they just start buying up the smaller ones and kind of rolling it
Yes.
into the big program. So I mean, you see that in the pharmaceutical and medical device realm. So I mean, I'm guessing it's the same thing. It's medicine. It's you're helping patients. So that's the path,
Yeah.
right?
Yeah,
Um,
absolutely.
so someone says they've heard of using Recovery Trek. Have you heard of that one?
I've not heard of that one, or this balance meditation and sleep app. There's some really interesting ones.
Calm. I know
Yeah,
Calm. And also with these apps, it's interesting now that like Calm, they have commercials on
they
TV.
do. They even have
So
puzzles that you can buy, and they have tea that you can buy. So there are companies like Calm that I often think have invested a lot of money in the marketing into making themselves household names.
yes,
Headspace is a little bit like that too, though I think to a less extent than Calm. But it used to be that you could go and you could buy yourself Calm tea. So
uh, yeah. I mean that's interesting. I guess I mean you got to spend those marketing dollars, right? To make. I mean they need to be profitable somehow.
yes.
Uh,
Yes,
so let's
especially when you're direct to consumer. So Calm
yeah.
and even Headspace are both apps that are still really predominantly focused on the direct to consumer, which again gets back to this cost issue, because it means that the people have to pay for it. And as of right now, that's not reimbursable. I don't even think you can use FSA dollars for these kinds of interventions. So it becomes a luxury item in some ways for a lot of folks.
It is. It is. So let's see. Balance is free for a year, but $90 after the free
Yeah.
trial,
The
which
free for a
is
year is really good.
that's actually because usually it's like free for 7 days or a month.
Yeah.
Um, but yeah, I do enjoy that at least these apps are doing like the free trial, because it's tough, right? You're starting something, and I know some out there probably aren't as user friendly as you kind of described earlier, that
Yeah.
it's difficult and you don't want to be locked into something that doesn't resonate with you. I think that's the way to go with almost all apps, right?
I agree. And I think without those free trials, the companies just wouldn't get signups.
Yes.
Because I think they capitalize on two things. One, if you came in and you looked at your app store and it said it's going to cost you $15 a month, without trying it, you're probably not going to do it. But two, I think they also, and this is probably not a great ethical practice, leverage the fact that when you download one of these apps and you do the free trial, they're usually asking you for payment information right off the bat.
Yeah.
And they count on people
Forgetting.
not remembering to cancel, right? How many of us have subscriptions that are ongoing that we're getting auto renewed, and then it auto renews and we go, oh crap, I forgot, I meant to cancel that. So I think there's some of that at play too, that if you can hook people with a free 7-day trial, how many months do you get out of them simply because they forget to cancel their trial? So
The same thing with gym memberships, right? People
100%.
that Okay, so we have someone asking, will there be a resource list provided of culturally competent mental health apps and therapeutic services available for rural communities? Northeast Louisiana is struggling to receive adequate care, even for serious behavioral health concerns.
I am happy, Ashley, to do some research and share that with you if you want to then send it out or post it as a resource list. I will admit that there are so many of these apps coming out now that I can't think of any of the big names that are really designed specifically for rural communities or diverse communities. But I can spend some time doing some research to see if there are some newer ones. Now, again, a lot of these are maybe accessible direct to consumer, which then involves a cost, or they aren't available to the public and you can only access them if you happen to be employed by an employer who offers it as a benefit or through a health plan that happens to have it. So that's really the tricky part. And I think it's the frustrating thing for me too, because when I came into this field, the idea was we can impact so many more people. But I think right now the model is making it where we still really do have an access issue. And it's not because we couldn't bring more people into the app. It's because of the way that they are marketed and costs involved. But I'm happy to try to do some research and provide some resources.
Well, that'd be great. We can share that with the audience. But yeah, so several people kind of commented in the chat, a lot of different ones that I've never
Yeah.
heard of. So interesting. Let's see. Social worker supervision used to do Zoom during the pandemic. Let's see. Recovery track. We talked about balance and meditation, sleep app, Calm. United We Care is also a good app as well. Interesting. Awesome.
Yeah.
Well, thank you everyone for kind of like putting those comments in the chat. This webinar has been recorded, so we'll put it on our website, foundationforwellness.com/DTx, if you want to share with your colleagues who missed this webinar. And as a reminder, everyone will get an email in about 1 week from info@Foundation for Wellness with information how to get their certificates. And if you dialed in by phone using the audio, please email info@Foundation for Wellness. And in that email, please put your first and last name and the phone number you dialed in with, and we can mark you as attended. And don't forget to register for our next 2 webinars coming up. The dates are on our website. Thank you so much. Thank you, Dr. Eliane. We appreciate you spending your afternoon with us. Thank you,
Thanks so much,
everyone.
Ashley. Thanks everyone for joining.
Thanks.